Well, the challenge to targeted therapy is a topic of what I was discussing yesterday in yesterday's plenary session. And I think it's very important to try and identify the mechanisms for resistance, which are complex, because it's not just the fact that you may have cells that are resistant to the drug, but you may have a patient that's resistant to taking the drug. So there could be issues of compliance or annoying side effects that you might occur when you take these drugs, particularly over a longer period of time. And I think sometimes patients will try to decide to get off therapy, perhaps more prematurely than they should, because of some of these toxicities. Fortunately, with the advent of newer therapies, we've been able to get newer drugs that also target these different proteins. And this protein that's being targeted currently is the BTK protein, our Bruton tyrosine kinase. And so we have now not just a Brutonib, we've also got Acalabrutinib, and now soon to perhaps be approved as Zanubrutinib. And these drugs are actually very interesting. Each have their side effects that you have to pay attention to, but by being able to choose between these different drugs, we might be able to overcome some of these annoying factors that may lead to lack of compliance or stopping the drug. There's also the problem of sometimes the enzyme BTK can incur mutations at position 481 in BTK, and this limits the ability of the molecule to actually form a chemical bond with BTK, and therefore the drug becomes less effective. So what we're seeing is that there's another category of these drugs that doesn't require that chemical bond. They have a longer half-life and they can inhibit the BTK without having to do this, and they may be effective even in patients who develop this resistant mutation. There's also a new category of drug too, which is the BCL2 antagonists. These are highly effective. They can influence the life and death of the leukemic cell and lead to the destruction of the leukemic cell in very quick fashion, such that we have to worry about problems of tumor lysis when we initiate therapy. But these have been very effective, either alone or in combination with anti-CD20 antibodies or in combination with inhibitors of BTK. And so what we're trying to do is find the right combination, the right strategies, whether fixed duration is adequate to get down patients without any detectable minimal residual disease, or whether we have to do maintenance therapy, or whether combination therapies can eradicate the leukemic cell in all these patients. We note, though, that even with all these combinations of drugs, we find that there are patients that are resistant to all the therapies. That means, combinations of venetoclax and Zanubrutinib and even the anti-CD20 antibody obinutuzumab. And about a fifth of patients may not clear what we call minimal residual disease. And half of those patients may be at high risk for disease progression, even if we continue therapy. So we have to understand why that exists and what are the genetic factors that account for that resistance. And we're identifying those. We found, also mutations in TP53 is very important. Genetic complexity, which is kind of a measure of genomic instability, is also very important. We also found a protein on the surface of the leukemic cell, which is called ROR1, which is a protein expressed in embryogenesis and then turned off, and for reasons that we're still trying to figure out, it's re-expressed on leukemia. So it seems to be an interesting protein by which we can target the leukemia and not target normal cells. But it seems like the cells that are resistant to some of these newer therapies may have very high levels of this ROR1 protein. We're trying to figure out exactly why that is and how it contributes to disease resistance, if at all. So these are some of the things we have to consider, but still we have to consider that most patients with these newer targeted therapies are doing far better than we did in the era of chemoimmunotherapy.